morning, and especially to be here with people who work on mental health in New York City. Over the last 50 years, I've worked in lots of places, including New York City. And I can tell you that doing good mental health work is more challenging in New York City than it is almost anywhere else. The complexity of the city, the diversity of the city, the layout of the city makes providing coordinated, integrated care a very, very difficult challenge. And I admire all of you who make an effort to do that and do that well. I'm sure you've seen this chart before, and it comes in many versions. It's a very, very famous chart. I've amended it a bit to make a point. When I started my research in mental illness in 1956, my first project was in a big state mental hospital in California, Avenue State Hospital. And at that point in time, we had about 550,000 people in state and public mental hospitals, and a population really of only about 170 million people. We now have a population of 313 million. Last time I looked, we had about 37,000 people in public mental hospitals. So that's been a dramatic change. Now, the usual story is that the pharmaceutical companies came along with Thorazine, and Thorazine emptied out the mental hospitals. And you see many, many sort of articles saying that, but in fact, that is really not a description of what really happened. As you know, the psychoactive drugs were introduced in mental hospitals in the middle 1950s, and you can see from this chart that there was some reduction in mental health populations between 1955 and 1965, but it was a relatively modest level of institutionalization. It really brought around sort of rampant deinstitutionalization, whether you think it's good or bad. But what really brought along that trend was the passage of Medicare and Medicaid in 1965, the tremendous incentives to the states to move patients out of hospitals for which they paid the total tab into institutions and contexts where the feds paid at least 50% and often more of the total tab. And it was the safety net development with Medicare, Medicaid, SSI, SSDI that allowed the support of patients living within the community. So in fact, what really brought about this massive change was a change in policy and the change in the safety net within the community that made it possible for the institutionalization to take place. Now, it didn't all take place in the community, as you know. Very often it was a transfer of patients from one institution where the states paid 100% of the freight to other institutions like nursing homes where the feds then picked up 50% or more of the cost. And that was a very, very strong incentive to state administrators. And then in the 1970s and 1980s, along came the civil rights movement for mentally ill, which came out of the larger civil rights movement, and that helped push things along in that process. And then more recently, we've had managed care kind of adding to that total deinstitutionalization or less use of inpatient care, but that is relatively small compared with the very strong incentives and forces that operated in policy between 1965 and 1985. Now, as you know, the trick in managed care has been a utilization review. This is just one example from one corporation, Xerox Corporation. In the private, as you know, managed care and utilization review began in the private sector with large corporations that had very generous health insurance, concerned about the growing cost of behavioral health. In those days, generally, the hospitalization pretty much averaged whatever the coverage was. Typically, the coverage was at least 30 days, so generally patients, when they were hospitalized, were kept in the hospital for 30 days and then released when their insurance ran out. In the 1990s, when these private companies introduced utilization review, as you can see in Xerox Corporation in 1990, when the average length of stay went from the 30s down to 13, and then by 1994 down to about 10. So these are the dramatic influences in the private sector, which ultimately were adopted by the public sector, and now much more, in a much more concerted way in very recent years. So we no longer are using public mental hospitals for providing inpatient care and mental illness. We were using general hospitals in the community, short-stay hospitals, as our major source of provision of care during psychiatric crises. And as you can see, the pattern, even within the general hospital, has been toward reducing average length of stay substantially over the period at a much lower rate. So in 1988, you had anywhere between an average length of stay between 10 and 13 days. By the time you get down to 2000, it's more like 7 days. It's now more like 6 days if we extend this chart. And as you can see, if you go back to 1988, the public sector had a much shorter length of stay than the private sector, private insurance, proprietary hospitals, and so on. But as we came to the year 2000, they all became very similar. So patterns of inpatient care now are not so distinct between the public and private sectors. Even in more recent years, we see within the general hospital, the short-stay hospitals, where most inpatient care now takes place in dedicated psychiatric and substance abuse units, average days of care have continued to go down up to 2009, the last year we have any data for. And as you can see, the slight decreases still continue in average length of stay. As I said, it's now about, on average, 6 days for patients that typically are quite seriously mentally ill. And there is a serious question as to whether we are now shortchanging patients and releasing them from the hospital much too soon, where their symptoms are still quite florid, but they are not really ready for successful adaptation in the community. We did, in the 1980s, we did a large study here in New York City in which we followed patients with schizophrenia on Medicaid coming out of 4 hospitals in the city, and basically found that many of them were just not prepared for community living on their own. And at the time, the community system of care was very poor. There was very little continuity between hospital care and community care. Many of these patients, as we followed them, became homeless, got off their medical regimens, got into difficulty, got arrested. They had very great difficulties because of the lack of coordination and the lack of a well-integrated system of community care here in the city. Also, patterns of spending has changed very dramatically. As you know, in the earlier period, almost all the money went into inpatient care. Now outpatient care is by far the largest component of expenditure. The other very large increase in recent years has been pharmaceuticals, where there's been an explosion in the use of pharmaceuticals for treating people with behavioral disorders, and very often in an inappropriate way. We'll get to that as I go on. Overall, there's been an enormous increase in the number of treatment episodes in mental health organizations. They tend to be short-term, they tend to be episodic, they tend not to provide, at least for those patients who are most seriously and severely mentally ill, the coordinated, intensive pattern of care which is necessary to really allow successful community living. And I'll come back to some of those issues as I go on. I would have thought that in the last couple of decades, where there's been so much interest, or so-called interest in behavioral health and attention to behavioral health, and major people, in a sense, becoming advocates for mental health at the federal level, presidents, vice presidents, figures coming out and talking about their mental illness. Presumably the thought was that now there was much more attention relatively to this neglected subpart of health insurance and health care of our total healthcare system. In that context, it is ironic that total expenditures for mental health, behavioral health, as part of all health expenditures, has been losing ground over time. In 1986, mental health substance abuse accounted for 9.3% of total health expenditures. The latest data we have is for 2005, where it now accounts for only 7.3% of healthcare expenditures. And of course, we know that in other areas of health, there have been dramatic technological achievements that are very expensive, cancer care and cardiovascular care, and so on. So in some sense, it's not surprising that these high technology subspecialties are taking up more and more of the money, which is another problem in terms of health policy. But it is also discouraging to see that over time, despite all of the attention and all of the so-called interest, expenditures for behavioral health as a proportion of our total health expenditures in this country have been going down despite the many, many gaps in care and inadequacies of care that are evident wherever you look. So generally, if we summarize what's happened in the last 50 or so years, we can make some generalizations. There's been much more broader insurance coverage. Most people who have insurance have some coverage for mental health, less substance abuse. That's going to change with the Affordable Care Act. Most care is now provided in outpatient settings, and many, many more people will receive some care. The inpatient care now is concentrated in short-term, specialized units in general hospitals, and typically with low and decreasing length of stay. If you compare psychiatric care with general medical care, behavioral health care is much more tightly managed than general medical care. As you know, there was a big backlash with managed care in the late 1990s. There was lots of complaining from doctors and patients about the intrusion of managed care. And the insurance companies, for the most part, have pulled back from tough managed care in general health care. They didn't pull back in behavioral health. Basically, behavioral health continued to grow in terms of its extent of management. And I would say, in general, it's true that behavioral health is much more toughly managed than general medical care. Now, in theory, parity is supposed to make care management equivalent. That is, the parity provisions deal with the both quantitative components, that is, things like a limiting number of visits, or total payments, or things of that sort, or co-payments, which are easy to monitor, but the Parity Act also requires that qualitative services have to be in parity. Now, that's a much tougher problem because it's hard to say what is parity between, let's say, surgical services and psychiatric services. And the final regs still have not been issued, and there's going to be a lot of litigation about this as time goes on. But I think it's fair to say that we're seeing more and more tightly managed behavioral health despite parity and the implementation of parity. It's only at the very beginning of that, since parity legislation, federal parity legislation is relatively new. What is apparent now is that the pharmaceutical companies and pharmaceuticals have come to dominate care in every aspect of care. And the pharmaceutical companies have been very dominant, not only in the provision of pharmaceuticals, but in selling those to the physicians, convincing physicians, a lot of direct consumer advertising, financing various study committees and practice guidelines committees, financing all of the major mental health advocacy groups. I mean, the pharmacy industry is in all parts of the sector, and now there is a backlash to that. A lot of people are saying that that's not appropriate, that The evidence overall, if you look at many, many studies, is that behavioral health care rarely meets evidence-based standards. And while there's a lot of it out there, it's often care of low quality. And this is particularly true with people with the greatest need, people with severe and persistent mental illness, who commonly do not receive the coordinated, integrated care that is necessary and get into trouble and more commonly are incarcerated in jails and prisons. It's a complicated issue, so I don't want to simplify it by a quick sort of general assertion, but I think it is true that because of our poor system of monitoring care of the most seriously mentally ill in the community, these patients very often end up being in jails and prisons rather than in good care and treatment programs. Here are some of the data that support some of the assertions I've been making. One of the studies that is most commonly referred to nationally are national studies of the American population by Kessler and his colleagues, the National Comorbidity Study in 1990-92, and the replication of that study in 2001-2003 with comparable measures, so you can make some comparisons across time. Basically, in the two studies, they found approximately the same prevalence of mental illness in the general population, but very large increases in treatment being provided. 50% of increase in treatment among those who had disorders, almost 100% increase in treatment for people in the population overall, and a 500% increase in using antidepressants in the population. The other very interesting thing about these data is that only half of the people receiving treatment had clinical DSM disorders as measured by these surveys. And these surveys aren't that precise, but generally there is no very careful allocation of care relative to the severity of clinical illness, and I'll come back to that in a minute. Here are some data also that come out of these studies looking at the severity of disorder, which of course is important. A lot of people have mild disorders in behavioral health as people have mild disorders in general health. And as you can see, about 40% of all disorders that are reported on are what you might call mild disorders. A much smaller proportion of the total are people with serious disorders, mood disorders, substance abuse disorders, anxiety disorders. By the way, this study does not measure schizophrenia, which of course is one of the most severe disorders, partly because these surveys are not very good in reliably measuring schizophrenia. But you can see that there is a real distinction in the severity among these disorders, and a good system reallocates care in a way that provides the greatest attention to those with most serious disorders, those who have the greatest need for care. And as I think I'll suggest as I go on, unfortunately our system does not allocate care effectively in relationship to seriousness and impairment, but rather kind of treats people in a fairly homogeneous way. The big player that has taken over for much mental health treatment has been the Medicaid program. As you can see from this chart, Medicaid is one of the predominant providers for outpatient treatment, prescription medication, and so on. So in the behavioral health field, Medicaid is the name of the game, at least for people who have more serious mental illnesses. And increasingly, with the expansion of Medicaid under the Affordable Care Act, Medicaid will even be a bigger piece of the action, a very, very important piece of the action. So the quality of the Medicaid program and how it's implemented has great importance for the future of mental health, as it does for the present, but even more so in the future. Here are some data on what's happening in the prescription area. As I said, prescriptions have been going up at an enormous degree. And as you can see, The big area is antidepressants, which have grown enormously in use over time between 1996 and 2008. Interestingly, a very large proportion of people who are getting antidepressants are depressed. And a lot of people who are getting antidepressants have only mild depression. And a lot of people with very serious depression aren't being treated. So it will be very difficult misallocation situation. And of course, most psychiatric drugs these days are not provided by psychiatrists. They're provided by general practitioners. I've been working on and off with the whole idea of providing better treatment of mental illness in primary care going back to the middle 1960s when I was at the Wesley in London, and the first such big program started at the Wesley in London in the middle 60s. We've been at this for 50 years, and we still know that the average physician, for a great variety of reasons, isn't very good at taking care of behavioral health problems, giving them appropriate attention, or even prescribing in an appropriate way. In any case, here are some recent data by Mojave and Olson that appeared in Health Affairs, looking at the prescription of antidepressants between 1996 and 2007. And what is most striking is that in a majority of cases, there is no psychiatric diagnosis. A patient comes in and complains, and these, as you know, encounters tend to be very short. People whose primary care doctors are under great stress. They generally hand out antidepressants without careful evaluation, diagnosis, or anything of that sort. And that's one of the problems and one of the issues leading to a tremendous expansion in the use of antidepressants in the population. This, once again, just simply reinforces what I just said in terms of the prescription of psychiatric drugs. 3/5 of all psychiatric drugs are being prescribed by general practitioners, primary care doctors, and so on. Psychiatrists are much more involved in prescribing mania drugs and antipsychotics. Even in the antipsychotic area, about 2/5 of the prescriptions are made by general physicians, often who know very little about behavioral health and behavioral health issues. And what makes that a really serious problem is that, and this is just one example of quite a number of studies, the antidepressants don't work any better than placebos for people who are not pretty severely depressed. They have some efficacy, and the efficacy is exaggerated, by the way. These drugs are not as good as you would come to believe if you listen to the advertisements and the promotions, or even if you read the literature, because the literature is so biased by selective publication and selective and inaccurate publishing of data by the pharmaceutical companies who now do most of the trials. But even then, the data on these studies tend to show that if people are not really severely depressed, these drugs really are just a placebo. They do no better than placebo. They have some efficacy at higher levels of depression. And yet the case for using them so generally and with such high prevalence is that these new SSRIs are such great drugs compared to the old antidepressants. In fact, there's no evidence at all that the new SSRIs are any better in terms of efficacy than the old drugs. They have some less dire side effects, which is important. They certainly are not more effective from all the studies we have. And yet we know at the same time that there are people who have serious depression and still don't receive care, still don't seek care. Here is one study done from the National Survey on Drug Use and Health by Mojave at Johns Hopkins, and he finds that about 38% of the population who have a depressive disorder receive no care. Many of those don't necessarily need care, but some proportion of that group do need care and are not getting it. Now, a lot of those people think they don't need care, and they don't think they need care for a variety of reasons which may not have validity. So, for example, here are the kinds of reasons people ordinarily will give for not seeking care when they have a disorder. And cost, of course, has always been a big issue, and not having adequate insurance was a big issue. But a lot of people say they think they can handle the problem without help. And people interpret that literally, but it shouldn't be interpreted literally. What people are often saying when they say, I think I can handle this problem, is I don't have much money, and I don't have insurance, and I have lots of needs for me and my family, and so I'm just going to struggle along with it and not seek care and try to handle it on my own. That is sort of a more plausible interpretation of what they're really saying than when they answer, I think I can handle it on my own. They're not answering that. That's one of the items in the surveys. But as you can see, cost has continued to be a major problem in providing mental health services and even more so substance abuse services. That presumably will change with the Affordable Care Act and its implementation. As you know, one of the great things the Affordable Care Act did that wasn't done by the Parity Act or some of these earlier acts is that it makes mental health and substance abuse a basic essential benefit that must be covered in health insurance. And that is going to sort of give more prominence to the treatment of behavioral health, although, as you see, we have some problems in implementation. The other issue, which I can't go into in any great detail, is that, and this is just one of many studies, which try to look at applying some guideline criteria to the treatment that is being provided. And basically, in this study, you can argue with the criteria, you might feel the criteria are too strict, but in any case, basically the study found that almost no patients who were receiving care were receiving guideline concordant care. And this was a particularly a bigger problem among minorities, blacks and Mexican Americans, less so among Puerto Ricans, in part probably because Puerto Ricans are concentrated in this part of the country where health services are much better and more accessible and so on. But in any case, it's bad all over, and we have a real challenge in bringing care up to a decent standard. I mean, there's a lot of care out there now, but the question is, how good is that care? It's important, particularly when we think about people with severe and persistent mental illness, that care is a lot more than handing people pharmaceuticals. We basically, for these patients with severe illness that is incapacitating in many ways, need a long-term treatment orientation. One where there are integrated services and serious linkage to social and rehabilitative supports. Housing is central. It's hard to treat people when they're on the streets. Medication management and illness and medication education should be a component of any good care. It's important whenever possible to involve families and educate families. If people are being treated for mental illness, it's terribly important that we also assess substance abuse through substance abuse screening and treatment if necessary. We need much more and better psychosocial rehabilitation. One of the best studied and most consistent, effective social services in the treatment of people with mental illness is supportive employment. The studies, there are now 17 controlled trials showing it works, and yet very, very few people who would be eligible for such services are now receiving such services. And of course, social and personal support is always important. So in a sense, when we talk about providing good services, we're talking about much more than handing people medications. So what are our challenges as we look to the future? Well, we still have a problem with ensuring access to care. And even if people have the insurance in many areas of the country, access to a psychiatrist is very difficult. For children in particular, it's almost impossible to get child psychiatric services for kids with very severe problems, like autism and so on. They may have to wait a half a year to see a physician. Now, of course, the system is not run by psychiatrists anymore. The system is overwhelmingly run by social work. People are doing a great job with the resources they have. But in terms of access for people who are very seriously ill and need careful evaluation to determine an appropriate diagnosis and treatment plan, very often that's not easily available. And it's not clear that extended services under Medicaid will necessarily make it available. Someone has to provide and coordinate the essential components of care, which I've already referred to. You have to worry about housing, appropriate housing. Someone has to be monitoring quality and accountability, and we don't do very well on that score. There has to be opportunities for useful activities and participation. Some years ago, we did a study of people with severe mental illness and asked them about what their needs were. And for most of them, many of them were not working, most of them were not working, but they were just going crazy with finding something to do, something to kind of involve them in some meaningful way in life, and developing ways of providing useful activities and participation is an essential part for treatment. Stigma is a big problem, continues to be a big problem, and barrier to care. For example, we've had a lot of attention in recent months on mental illness due to the Newtown massacre and so on. But very often it's been negative, it's sort of let's find these mentally ill people and find a way of restricting them. So while there's a lot of attention for behavioral health, it's not necessarily all positive attention. We obviously know criminalization is a big problem, and ways of reducing that are important. There are more programs now, although not enough, to try to defer prison and jail and reassign people to mental health services. We're beginning to use mental health courts more as a way of doing that, with some success using substance abuse courts. But that's still a pretty early trend, and it still doesn't reach most people. And then we have to particularly pay attention to those clients who are difficult, resistant, and very, very hard to treat. Those typically have substance abuse comorbidities as well as mental illnesses, and there's a very poor treatment adherence, so one has to have a concerted effort to deal with the problems of treatment adherence. This is a study we did, just to give you some example of, it's a national study we did with the Rene Corporation in Los Angeles, in which we followed people with severe mental illness who we identified during our first survey in 1997, 1998, and then followed up the same people in 2000, 2001. And I just address you to the top line, which are people who met the criteria for severe mental illness in both waves of the survey. And what I think is important about it, I can say a lot of things about this, but the thing I focus on and emphasize here is that no more than at most 50% of these people with severe mental illness during the prior year to the second interview had received any specialty behavioral health services. Or they may have received some other services, but they would have not received any behavioral specialty health services. And this is a very impaired population, so we're not doing a very good job in taking care of these people. The other thing that's very, very disconcerting is the growth of using very powerful antipsychotics with young children, as young as 2 years old. And that trend has been growing over recent years to a considerable degree. This chart only deals with ages 6 to 17. And actually what's interesting is that this trend of use of antipsychotic drugs with young people is going up very substantially in the Medicaid program. And of course, the Medicaid population is different than the private insurance population, so there may be some justification for that. However, it's going up very, very rapidly, and no one really understands why, and it is of great concern. I might say this morning, I was looking at the March issue of Psychiatric Services, and there is an article in there by Julie Cito, who's a person who's contributed a lot to this area of understanding pharmaceuticals. I assume the state that she's writing, she doesn't identify the state, but the state she's writing about, I believe, is Maryland. But in any case, she reports the same pattern of a tremendous increase in use of children, particularly those children in public safety net programs. And basically, she reports that a majority of these children are not getting these antipsychotics for psychiatric illness, they're getting it for behavioral problems. So in a sense, you have behavioral problems, you can't control the kid, you throw antipsychotics at them. Now the problem is that, young people's brains are developing, and especially early in life, they're developing very rapidly. But we don't have a clue as to what these drugs do to brain development. And so this sort of tremendous increase in the use of these drugs with children is really a really concerning issue that we really have to understand a lot better than we presently do. Now, the Affordable Care Act offers us considerable optimism that things can improve. We will have the population will have broader access to Medicaid among those people who are now uninsured or severely underinsured. Well, I'll get to the Supreme Court in a minute. There are also subsidies for people who are not eligible for Medicaid up to 400% of the federal poverty level, which allows people to get subsidized insurance for people who are not now insured. There is no longer any exclusion for pre-existing conditions. Psychiatric conditions were typically an exclusion for getting coverage. For those without insurance from employers, they will have access to health exchanges where these subsidies will be applied. And hopefully, depending on how these health exchanges develop, there will be minimal standards for good insurance, meaningful coverage that is guaranteed under the policies covered under the exchanges. As you know, some Republican governors, many Republican governors have been opposing and not cooperating in establishing the exchanges. And the legislation says that if the states don't do it, the feds will do it. So the feds are going to be doing this in many states, including my state, New Jersey. So that's been a problem, as it has been with Republican governors agreeing to extend Medicaid under the provisions of the Affordable Care Act. One of the really wonderful things about the Affordable Care Act is it provides lots of money and opportunities for demonstrations, innovations in chronic care management, better services integration, and the health homes in particular offer a great opportunity for substantially increasing mental health services for people with severe and persistent mental illness. I'm pleased that New York State is moving ahead on health homes. I was at a conference just a few months ago where I heard about some of the health homes that are being developed here. Other states have moved very rapidly. Missouri, Rhode Island, quite a number, Washington, have moved in developing these. The advantages of the feds for the early years will pick up 90% of the costs, which is a great advantage for something that should be done in any case. And then, of course, we still don't know how parity will be implemented, what the final guidelines for non-quantitative services will be, and that will have to be worked out over many years. These things don't happen. Implementation doesn't happen immediately. So, as I said, hopefully more states will take advantage of the opportunities to develop health homes. They're also developing medical homes, which in theory are supposed to pay much more attention to behavioral health, which is now one of the basic health services. There are other opportunities under the home care and home care services to do some things that weren't allowed before. And there are other programs, including the programs now being developed by the new Office of Medicare and Medicaid Coordination, whose population, that is people who are both core Medicare and Medicaid, consists of about 40% of the population with mental illness. So what they do will be very important in this general arena. These are very high-cost patients within the whole context of American health care. So what are the barriers? The barriers, of course, is that the Supreme Court limited, originally the feds would have had the power to withdraw Medicaid funds from those states that didn't extend Medicaid to 138% of the federal poverty level. But the Supreme Court said that was too coercive, and the states didn't have to do it and couldn't lose their Medicaid money if they didn't do it. And as a consequence, different states are choosing to do it and others are choosing not to do it. The states that so far are the most resistant, the most vocally resistant, have been very conservative states, states with conservative Republican governors. Well, this is a great deal. This is a great deal for the states. The first several years, the feds pay 100% of the cost. And then the feds, over time, reduce their support so that by 2020, it's only 90% and it stops. It continues to be 90%. So there's tremendous, the feds are going to pay most of the cost of this. So any rational decision by a state would be to obviously do this. However, ideology prevails in many states, and some states are just saying they're just not going to do it. Texas is one of the extreme examples, which has a gigantic uninsured population and very poor care overall, and their governor is standing pretty firm that he's just not going to do it. Other Republican governors have given in. Florida, legislatures raising issues in Florida as to whether they're going to go along with it. So, I mean, some Republican governors are getting the message. Ohio, they're getting the message that really this is a good thing. It's good for the state. It's good for the people of the state. And even though it's against their ideology, they will cooperate. But it's still going to be uneven. And as a consequence, we're not going to get as many people insured as we had originally hoped for under the Affordable Care Act, at least initially. Over time, I guess most states will come in because it's just too good a deal, and they're going to be heavily lobbied by the hospital industry, the pharmaceutical industry, and all of the people who have to be the providers, all of these people who have a stake in expanding the system. I've lost the Anyway, that's basically the story. A lot depends on the implementation. We're not going to know about the implementation for a long time to come. It's a gradual process. It's iterative. But I think there are many opportunities to the extent that the Affordable Care Act isn't sabotaged. And many people trying to sabotage it. There's a proposal right now in terms of the upcoming issue about the budget. The Republicans basically want to take away the money for implementing the Affordable Care Act, which the Democrats can never agree to. There will be part of the impasse that will occur. So we are in a situation of very ugly politics, which in a way will get in the way of doing the right thing for people who need care with severe persistent mental illness.